लैपटॉप पे?
टाइम का तो आई थिंक आशा इज ए बेटर जज.
Good evening, Asha.
नमस्कार मैडम.
हेलो डॉक्टर शुभा.
हेलो मैम.
Hello.
हेलो.
हेलो डॉक्टर मैम. डॉक्टर किरण मैम. हेलो.
हेलो. हेलो.
हेलो किरण मैम, कैसे हैं आप?
बिल्कुल बढ़िया, बिल्कुल बढ़िया.
नॉर्थ जोन के बाद आज बात कर रहे हैं.
हाँ जी. अभी थोड़ा सा बाहर थे तो वापस आके फिर शुरू करते हैं कुछ ना कुछ एक्टिविटीज.
डिटो, ये स्ट्रीम नहीं हो रहा. मैंने स्ट्रीम लिंक को किया मगर ये हुआ नहीं. किया मगर
शायद
ये
मेरी
हुआ
दुआ लग
नहीं.
गई है.
किया मगर
ज्यादा दुआ मत देना.
done. So thank you so much. Now we are live and I will be sharing so welcome to the 39th edition of Searchlight series of webinars. Today we have faculty from Bangalore, Bhatinda, Bhimavaram, Faridabad, Jalandhar, Ludhiana, Palwal, Raipur, Rewari, and Yamunanagar Society. So I hope this update on premature ovarian failure will give you key take-homes to make your practice richer and your time spent here worthwhile. The convener of the series is Dr. Sujayasri Sangita, who's the secretary of Bhimavaram Society. Due to a family emergency, she has not been able to join in. I am the program director, Dr. Asha Jain, and I hope you all know me. So I thank all of you for electing me as chairperson for drug committee.
Congratulations, ma'am.
Thank you so much.
Congrats, Asha.
Congratulations, Dr. Asha.
Thank you, ma'am. Thank you. Now we all take the name of the divine before we start the academic program. I hope you all join me for this prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा.
With that prayer, we take the program forward. My coordinator is Dr. Purvi Agrawal, who is an executive member of Society of Fetal Medicine. And our guest for the evening is Dr. Maninder Ahuja, ma'am. She is founder and committee chair of Midlife Management Committee. And I will be reading her CV, which is a pleasure. But more than that, Madam is here to tell us that age is just a number. You have to actually work to keep your body mind healthy. And if you keep your body mind healthy and work towards it, then age is just a number. But like everything else, you have to devote some time and energy to that as well. Her tagline is "Actions speak better than words," visualized and inspired the process of digitalization of Foxy and IMS, emailing, e-newsletter, online voting. She is honorary professor of IMA. She is an academician with more than 45 years of work on holistic health of women. The brief highlights of her academic journey are that she has more than 20 years with Foxy and Women Holistic Care, founder, vice president, and president of FOGS 2004, founder and committee chair, Midlife Management Committee 2009 to 2012, VP Foxy 2013-14, national and international faculty, GCM of ICOG 2015 to 17, has attended almost all MCM of Foxy since 2009, ex-member of many other organizations like IMS, ISAR, ISPAR, and NARCHI. He has more than 150 publications, 26 research articles, chapters in books, and more than 235 citations of various papers and original research. She is editor-in-chief of Journal of Midlife Health, PubMed peer-reviewed journal. She has the President Foxy Awards and awards by ISAR, IMA, IMS, and social organizations and NGOs. She is a proponent of artificial intelligence, active on all social media, Facebook, Twitter, WhatsApp, and LinkedIn. First e-newsletter of Foxy advocated online voting. So welcome, ma'am. We are really happy to have you with us, and we would love to hear words of blessing to this webinar and also guidance for what we should be doing. Welcome, ma'am. Over to you.
Asha Jain, thank you very much for those kind words. I think more than I needed. I am humbled by that introduction also. And congratulations to you on being elected as the chairperson of the Food and Drugs Committee. I think that has become a very important committee over the years and had many, I think, tentacles like octopus it has. So you have lots of work to do, and I have complete full faith in you that you are going to do your best as you have been doing already. So the topic for today, and welcome to all these our members who have come from all these societies of North mainly, but South also, Bangalore, Bhatinda, Bhimavaram, Faridabad, Jalandhar, Ludhiana, Palwal, Raipur societies. All these societies members are there. So Asha, you are fulfilling that dream of reaching out to everybody at distant places also. And that is very important. Like Shraddha was saying, this is a sort of not only academic exchange, but personal exchange also. So multiple our agendas are fulfilled by these webinars. So I wish you best for your future webinars also. And today's topic is very, very important. Premature ovarian insufficiency. And it has become very common also now. It used to be said that about 10% of the women now are going into this premature ovarian insufficiency and can manifest in many ways. So that's why it's very, very important, because it can just manifest as a secondary amenorrhea, as a oligomenorrhea, as irregular menses. And patient's presentation can be as an infertility patient. If she has not conceived, she will be presenting as infertility patient, or she might present as secondary amenorrhea. But what are the offshoots of this premature ovarian insufficiency? That there is, of course, going to be estrogen deficiency, as we know. It is because of the depletion, early depletion of the ovarian follicles before 40 years of age. When our age of menopause is 46 plus minus 4.6 years. Now, if it occurs between the age of 40 and 46 years, we say it's an early menopause. But if it occurs before the age of 40 years, then it's a premature, or it's a premature ovarian insufficiency, which is called, because patient can be having her irregular menses also, but she will be into insufficiency. So presentation, I said, can be like this only. But the after effects of premature ovarian insufficiency are going to be on her skeletal system, osteoporosis, on her cardiovascular system, cardiometabolic system, more metabolic syndrome, more cardiac events are there, CVD risk is increased. So these women will have early menopausal symptoms, which can increase her morbidity and mortality, both. So we have to be very, very vigilant in these patients. And of course, in the discussion in the panel, you are going to discuss the various aspects and how you should be treating them. So menopause, this is the one indication where we have to give the therapeutic menopause hormone therapy. So this is actually the menopause replacement, hormone replacement therapy. Now, otherwise, we are calling it a menopause hormone therapy when indicated. But here, in reality, we have to give replacement of those hormones. So dosage is always required more than the normal doses in these patients. And they say perhaps till the age of menopause, we can give the OCPs also. But all these points, I think we will be discussing in our panel only. The only thing is, this is very, very important to diagnose when the patient's infertility patients are coming up. We deliver them by giving the ovum donation. That is the only way possible for them. Because below a certain level of AMH, 0.5 AMH, you cannot have the patient's own ova, because they won't be even healthy even to produce in these women. So we need the ovum donation in these cases. For IVF has to be done if the real premature ovarian insufficiency is there. So for other, we have to give menopause hormone therapy. Look into the weight of these women, waist of these women, cardiac profile of these women, lipid profile of these women, blood sugar of these women. Please follow them up yearly or so that they don't land up into adverse effects later on in the life. Because if we diagnose these things earlier, we can take the proper preventive measures. I think with that, Asha Jain, I wish you best. And then we will be inviting I think you will invite your first, because this is very important that you are taking up the ultrasound picture first as the speaker, because ultrasound findings are very, very important. Sometimes the AMH will be not validated from the labs and everything, variable readings you can get. But the ultrasound picture of antral follicle count is the one which is going to tell you about the actual hormonal profile of these women also, correlating them to the endometrial thickness and vascularity of the follicles and everything. So wish you again, Asha Jain, best for your webinar series and for this webinar also. And to you, Dr. Asha Jain.
Thank you so much, ma'am. Thank you so much, Maninder ma'am, for being kind enough to join us and being a beacon of light for all of us who are aging, that yes, aging can be beautiful, it can be graceful. Thank you so much.
Thank you.
And now I would like to introduce a very senior but very dear friend, Dr. Shubha Rama Rao, ma'am. She is the president of Bangalore Menopause Society. She was president of Bangalore Obstetric Gynec Society in 23-24. She retired professor and HOD at St. Martha's Hospital, Bangalore. She is a DNB teacher, guide, and examiner for 34 years. Her areas of interest are teaching, high-risk pregnancy, vaginal surgeries, preventive oncology, menopausal medicine. And I have had her in my series a couple of times. Ma'am is very, very knowledgeable and very humble, very loving, always ready to accept when I call her in time of need. So welcome, ma'am. Thank you so much. Over to you to introduce Venus ma'am and also say something about the topic.
Yeah. Thank you, Asha. It is Dr. Asha. It is indeed a pleasure being here on your webinar series. And I must say, of course, congratulations to you on your elections. Also, I must say that you really have taken so much pains, and you have really taken good topics for your webinar series. And I had the pleasure being on your webinar for I think 2 occasions previously. So indeed, you are, making great efforts to spread knowledge, reach corners, and by your method of involving so many societies, you're really reaching the corners of the country. So this is a good way forward, and all the best for you for all your endeavors. And I think you will have a very fruitful uh, uh, innings as the chairperson for the Food and Drug Committee. So thank you for having me here, and it's indeed my pleasure to introduce Dr. Venus Bansal. And today's topic is indeed very, very important because we are seeing premature ovarian insufficiency in a lot number of patients. I won't repeat what Dr. Maninder has already said, but in practice, I have seen that this post-COVID pandemic, there are many women who are coming with, premature ovarian insufficiency, and their problems are a huge spectrum. And we have to really address their problems and treat them properly for their future. So we will have a lot of insights into this topic today. So it's my pleasure to introduce Dr. Venus Bansal, who is a senior consultant, gynecologist, is a senior consultant, and her CV is so long. Dr. Venus is a highly qualified and experienced obstetrician and gynecologist. She passed out. She did her MBBS from Indira Gandhi Medical College, Nagpur University, and she pursued her masters in OBG from sorry, I cannot. From Dayanand University, Rohtak, in August 2008. Currently, she is heading the Department of Obstetrics and Gynecology as a senior consultant at
It's PGI.
Ludhiana, PGI Ludhiana.
PGI Rohtak was my postgraduate institute, ma'am, and it's
Okay.
yeah.
So my apologies, I'm finding it a little difficult to read it on the screen.
Fair enough, ma'am.
Dr. Venus is a trained laparoscopic surgeon and fetal medicine. She has done from AIMS, New Delhi. She has managed 1,000 plus cases of high-risk pregnancy, 3,000 laparoscopic surgeries. Wow, that's a real great number. And more than 500 cases of critical obstetric cases. So she is affiliated, of course, to FOXY, Society of Fetal Medicine. And why has the screen changed? I don't see the CV on the screen. Yeah, okay.
Now she has to share her.
Yeah, now it's come. So she has contributed immensely to the field of gynecology and obstetrics. And I wouldn't take much more time. We have Dr. Venus who will talk to us on many aspects of premature ovarian insufficiency. Over to you, Dr. Venus. Sorry for having, made some mistakes.
Oh. It's really a pleasure to me to hear it from your mouth, ma'am. You are such a senior person, and I would really love to do justice to this particular topic. First of all, I would like to thank Asha ma'am for inviting me for this. Meeting her is always a pleasure, and all the people on the board. I made some new friends just now, and it was a good start of the webinar. Thank you so much for the idea behind it and the brainchild of Asha ma'am. I hope we are going to enjoy the panel discussions, and we are going to have a good, academic evening today. So I would like to share my slides. Asha ma'am, are my slides visible?
Yeah, they are visible. You need to make it
Yeah.
full screen. Yeah, done.
Done. So without taking much time and really bowing in front of all the senior faculty sitting here with all of them and with friends, Ruchi and everyone. So I would like to start with a very, very common problem, I would say, because we were not seeing so many cases earlier and late detected, late treated, and hence the problem. So we are going to take a topic which is coming up frequently now and is diagnosed quite a bit late. And because of that late diagnosis and late treatment, we are still facing all the challenges that we expect when our beautiful ovaries, they fail secreting the estrogen, which is our own hormone, and hence the problems that come out of it. So we define it as a cessation of ovarian function, means that our ovary, which were doing all that cyclical dynamic function every month, they have come to a full stop much before when they actually should have stopped. Accompanied by what decreases with it? The estrogen. The estrogen, the female hormone, the pride of a female body, that decreases, and we start, and the body of that girl start behaving like a post-menopausal or a menopausal years of the age. And it happens quite early. It happens before 40 years. There is a sequence of the thing that happen. Initially, it will be a insufficiency, then it will be a complete failure, and there is new term that is coming up like an early menopause when it comes between 40 and 45. So these are all spectrum of the diseases and the spectrum of the cessation of the ovarian function at a different speed, at a different age, and leading to a ovary which is going to give us less function over the time. This condition differs from menopause in that there is a varying and unpredictable ovarian function in approximately 50% of the cases. And in about 5 to 10% of the women, they conceive also in between. They deliver a child after they have received the diagnosis of premature ovarian failure. So here comes the trick, because we are telling that your ovaries are working insufficient or they have failed. So before declaring it failed, we must tell her that there are erratic ovulation that can happen, and hence there can be at times the conception. If she is not desiring it, she must understand that it can also happen in between. So my screen is coming not visible to me actually. Right. Why it is important to study a premature ovarian failure? Because one thing, as we all know, that the menstrual problem and leading to the fertility problem that is going to happen, the serious, it comes under a group of serious endocrine disease. So it is not only the dynamically cessation of menses or a cessation or decrease in the fertility or a cessation of the only estrogen level. It behaves like a metabolic syndrome as we talk about PCOD and all. And it behaves like a serious endocrine disorder, because what happens that it increases the twofold in the mortality due to the cardiovascular disease, stroke, and osteoporosis. And everyone here from the midlife society, they talk a lot about the CV diseases, a stroke and osteoporosis, and definitely this particular group of the female having a premature ovarian failure, they hold a special place in that crisis group. Slides are not moving.
Ma'am, you may stop sharing and share once more.
Yeah.
If they are not moving.
So then there are multiple nicknames. Yeah, it has started moving, and it says that I'm not ready to fail. The slides PPT is saying that we are not ready to fail so prematurely before the talk is going to end. The nicknames given to this is the gonadal dysgenesis, the premature ovarian failure, hypergonadotrophic hypogonadism, early menopause. As I told that these days we don't take early menopause in the same nicknames, but before 40 we call it premature ovarian failure, and usually between the early 40s we call it early menopause. Ovarian dysgenesis, primary ovarian failure, hypogonadotrophic amenorrhea, and climacteric precox. This is one of a fancy name given to this. So these all names somehow relates and fit to some extent in the same diagnosis. The prevalence and the clinical symptoms that stands to 1 to 1.2% in the women nearly 40 years or younger. So if we are seeing 100 patients per day, there is a possibility that we get to 1% of these, the menstrual disturbances patient might be having this premature ovarian failure. 10 to 28% of the women presenting with the primary amenorrhea, they never have any menses, and later on we come to know that they are having some genetic disease like Fragile X, or they come as a primary amenorrhea, and they later on add on as a diagnosis as premature ovarian failure because it comes as a symptom under that. 4 to 18% of women, it is the secondary amenorrhea. What we usually see in the clinical practice is that we usually see these patients with a secondary amenorrhea, because usually the primary amenorrhea first reaches the pediatrician and then they are referred to us. The age ranges 1 in 10,000 women at the age of 20, 1 in 1,000 by the age of 30, and 1 in 100 by the age of 40. So this is the age graph that we follow. The etiologies can be genetic, it can be a dysgenesis at the gonadal level, or it can be iatrogenic. Familial ovarian failure, Fragile X syndrome, and with the advent of genetics, if I share my personal experience, we are actually getting these diagnoses in hand these days. There was a time when we were postgraduates, and whenever such kind of amenorrheas used to come, most of the time we didn't had a cause or an answer to be given to the patient. But with so much into the genetics that has been researched, we are getting a diagnosis of most of these cases which stop functioning their ovaries earlier. The same hold true for even the neurological diseases in the baby, or the metabolic, the mitochondrial syndromes in the babies, that the mother is having one baby and they come to us for the second pregnancy, and we are able to now give them a better diagnosis. The genetics has actually worked like a wonder for all the obstetrician and the gynecologists. In gynae per se, this is one of the kind disease which is helped a lot by the genetics. The small X chromosome defect, the small deletions, the micro deletions, FSH, LH receptor mutations, they all come under the genetic causes of it. And yes, we are asking for these tests whenever we send the genetics of the patient, whether we have to ask for the whole exome sequence or we have to ask a particular gene depending upon the phenotype of that patient. Then the gonadal dysgenesis, 46XX gonadal dysgenesis and 46XY gonadal dysgenesis come under this preview. The Turner's and the Pollitt syndromes, they are common ones, but Turner's have a very, very specific features and they are usually diagnosed very early. So late diagnosis doesn't remain, the problem in Turner's. Iatrogenic, this is one thing that has come up very frequently, I think all over India, but particularly in Punjab, if I say, we are seeing a lot of young cancers. The environment toxins, or the diet, or the lifestyle, all the things together, they are responsible for some mutations that are happening in the young kids, and they are undergoing chemotherapies and the surgeries, and wrongly, or I will say not wrongly, but less carefully done surgery at times lead to damage of these ovaries. If we have not preserved the ovaries away from the radiation field, we may lose our ovaries forever. So that is another thing that come up, and with the oncologists and oncosurgeons, now we are trying to decrease the number of such kind of iatrogenic causes. There is one more iatrogenic thing that happens all over India, and we hope as a gynecologist that will stop someday. That many a times there is a patient with simple ovarian cyst or a small cyst adenoma. They are operated in the periphery by some surgeon, and they remove the whole ovary rather than just removing the cyst, and that becomes one of the causes of premature ovarian failure. So that is a challenging task, because every kind of surgery is allowed to everyone as per the rules that are there in the government policies till date. And I think whole of the gynecologists who are sitting on the platform here will agree with me that they must have seen one or two cases in their life where they find that it was a just simple ovarian cyst on the ultrasound, and the patient came with a salpingo oophorectomy done to us after 2 years, 4 years, when they get married and they want to conceive, and they have that kind of requirement at that time. Now, autoimmune ovarian failure is that when the own cell, they start destroying our own body, and the autoimmune changes they develop. Polyendocrinopathies is one thing. I have not studied it in very much of detail. I have never seen a patient of polyendocrinopathy, but it comes under the list of the causes, so I have to put it. So viral oophorytis is another one, and certain enzyme deficiencies like cholesterol desmolase deficiency, 7-alpha hydroxylase deficiency, 720 desmolase deficiency. And believe me that we are able to get the diagnosis of these when we ask for the detailed genetic studies in the patients. Now, how do we evaluate and diagnose these patients? There are minimum 9 menstrual cycles per year are what we think of. Now it has come down to 8, and missing more than 3 to 4 cycles consecutively should be evaluated. So what are the causes that come up? That is amenorrhea, elevated gonadotropin levels, and all the signs and symptoms that we can think of the estrogen deficiency, which I remember as all the things that a patient of a menopause or a perimenopause come to us. They start appearing in the young female, and that should deserve the attention of the gynecologist treating that person. Vasomotor symptoms, they will come up. The urogenital symptoms, which are not expected in that age, they start coming up, and to some extent multi-system dysfunction may come up. So symptoms of the estrogen deficiencies can be summarized with from head to toe we can take it, or just the common to less common ones: the hot flushes, night sweats, emotional liabilities, vaginal dryness, decreased lubrication, dyspareunia, lack of libido, impaired sexual satisfaction, loss of vaginal rugae on examination, shortening and narrowing of the cervix, frequency, urgency, incontinence, and atrophic cystitis, headache, irritability, dementia, osteoporosis, joint pain, and cardiovascular diseases. Now, patient may come up with anything, and we need to correlate it with her hormonal profile. FSH, any FSH more than 25, here it is written 30, we take it more than 25 milli international unit per ml. And when it goes more than 40, then we say it is failure. When it is 25 to 40, we say it is insufficiency. It is at least should be measured at 2 occasions, more than 4 to 6 weeks apart, to confirm the diagnosis, as FSH levels may differ according to the cycle, durations, the timing when the sample has been withdrawn. So there is a variations. So we always take a double value as a perfect marker for diagnosing them. If FSH level is more than 10 milliequivalent per ml, except during the mid-cycle, it may suggest a failing ovarian function, but this is something that has to be kept initially, I think, in the mind of the gynecologist, and that need to be followed. I think most of the time we don't tell the patient that there will be something bad that may come up, because it is not that common that it is going to be there, but we always keep it in mind, and the mid-cycle has to be thought of. If FSH level is always greater than LH levels, it suggests that almost nil ovarian function is happening. So LH levels are consistently higher than the FSH level in the presence of significant estradiol secretions by the ovarian follicle. So this is an indirect marker that we can, get out of the results. Like interpretation of CBC, we learn. Similarly, the interpretation of the LH, FSH, estradiol, the cycle, mid-cycle, proliferative phase, luteal phase, all these things have to be kept in mind along with the symptoms that the patient is presenting. And in combination, we come to some conclusion and a decision that when we are going to repeat this particular test. Thyroid function test, prolactin, inhibin B, and AMH. AMH is now coming up as a good marker, but as Dr. Maninder Ahuja ma'am has said, that there is a lot of variation in the measurement of these levels. So ultimately, that comes up as a great help is the ultrasound. The pelvic ultrasound is needed for the evaluation and remains a mainstay because the antral follicle count is very, very important. Now, for the girls who are sexually active or are married, transvaginal ultrasonography is the best thing that we can do for counting the follicles. In unmarried, transrectal or transperineal can be offered, but the radiologist has to be trained enough to give us a good antral follicle count. So when the transvaginal is not available and the transrectal, we are not, at times get the radiologists who are very well convinced in giving that report to you, and many a times patient also refuses that I don't want a transrectal one. Then by the abdominal ultrasound, it may become difficult for the us to get into the diagnosis of this. So chromosomal analysis, as we have listed already, the autoimmune screening, anti-adrenal, autothyroid antibodies, bone mineral density for osteopenia and osteoporosis, or ovarian biopsy is not needed. Rather, I will say that it is contraindicated, because whatever tissue is left, we are going to take that also out. Resistant ovarian syndrome is a medical condition that presents as a clinically identical to POF, but the ovary has normal amount of oocyte in that, and they present like a ovarian failure. So autoimmune diseases that we need to look along with this are the thyroid diseases, hypoadrenalism, hypoparathyroidism, type 1 diabetes, mental retardation, and ataxia. The National Institute of the Child Health and Human Development, NICHD, states that the ovarian function cannot be restored by any proven therapeutic strategy till date. So reduce the psychological trauma on their emotional health. So the counseling, the repeated counseling are needed in these cases. Manage the consequent infertility, prevent long-term effect of the estrogen deficiency. So these three remains the basic treatment modalities. Manage the hypoestrogenic state linked to the POF to prevent the long-term sequelae. Lifestyle changes that we advise to these patients is the lifestyle modification must be recommended to reduce the risk due to the cardiovascular diseases and the osteoporosis. Daily intake of 1000 milligram of calcium and 800 international unit of vitamin D is recommended. Regular weight bearing exercises, reduction in the caffeine. They can go for the decaf options, avoiding smoking and alcohol for all the good outcomes. So fertility management can be done with we can just wait for that. There can be a possibility of spontaneous conception for 5 to 10% in these cases. Then the ART can be given them as an option. Minimum ovarian reserve, conventional ovulation induction with the exogenous gonadotropin and pre-treatment with the estrogen, followed by the ovulation induction protocols, have been tried. Confirmed premature ovarian failure, if it is there, then oocyte donation remains the most effective form of the therapy. And thanks to the good IVF laws that have come up, and we have got good donors and in a very legal manner these days. Women on the menopausal hormone replacement therapy should use an additional method of contraception that has to be told if we are keeping them on that. So oocyte donation, the review has been done and has proposed that in 2011 that donated gametes are the only realistic strategy for the women with POF to achieve the motherhood, and it has a very good success rate to the tune of 40 to 50%. So it becomes one of the good indication for the donor oocyte ARTs. Strategies for the fertility preservation in the young cancer patient is ovarian suppression with GnRH agonist 7 days prior to chemotherapy, continuing every 28 to 30 days throughout the chemotherapy duration, transposition of the ovarian tissue prior to radiotherapy, at least more than 1.5 centimeter above the iliac crest, cryopreservation of the mature oocyte and the embryo prior to chemo, radio, or BRCA half carrier before the prophylactic oophorectomy. Menopausal hormonal therapy is advised to alleviate the symptoms of estrogen deficiency, to make them feel more comfortable and just to forget at times that they have a failing ovaries. This therapy gives wonder. In adolescents, to induce the secondary sexual characters, it can be used. Prophylaxis for the osteoporosis and the cardiovascular disease that we fear in these patients. So doses of the estrogen that are recommended in these cases is 0.625 to 1.25 milligram per day of conjugated estrogen or transdermal estradiol 100 microgram per day. It is advised to avoid first pass hepatic metabolism. Oral estradiol 1 to 2 milligram per day can be given. The circulating levels that come up to the tune of 100 picogram per ml, micronized progesterone 100 to 200 milligram per day, or medroxyprogesterone acetate to the tune of 5 to 10 milligram per day for 12 to 14 days per cycle, usually given for 3 to 6 months and then slowly reduced as per the symptoms of the patient, because the only indication is the menopausal, the symptoms that are troubling the girl. Global consensus statement on the MST on premature ovarian failure is most effective treatment for the vasomotor symptoms associated with the menopause at any age. Systemic, the replacement is recommended at least until the average age of natural menopause. And that is why we need the early diagnosis and the early treatment in them. Estrogen as a single systemic agent is appropriate in the woman for after hysterectomy, but additional progesterone is required in the presence of uterus, as is the case in the other MSTs. MST is effective and appropriate for prevention of osteoporosis related fractures. Standard estrogen therapy along with women less than 60 years may decrease the coronary heart diseases. Local low estrogen therapy is preferred for the woman whose symptoms are limited to the vaginal dryness and dyspareunia. So we can discuss the options with her, the safety of the same. The dose duration of the MST should be consistent with the treatment goals, and the safety issues that should be individualized and thoroughly discussed with the consent. Current safety data doesn't support MST on breast cancer survivors. Management of vaginal atrophy, topical estrogen cream, topical DHEA cream, and the systemic hormone therapy. I am a more frequent user of estrogen cream, not freely available DHEA cream is there. So non-hormonal treatments, lubricants, phytoestrogens, there have been certain studies on them that the red globus and all helps. I think it is the personal choice of the gynecologist that should hold true in these cases, or you can just hit and try the treatment in such cases. Vitamin E, vitamin D supplements I usually give as per the symptoms of the patient. Oral pilocarpine, that is also vaginal lubrication that is available, and 5% lidocaine or 5% gabapentin. So how, I think case discussion and the panel will come up. So I will skip the case because this is a case that I have taken up. I will directly come up to the take-home message. That is about 60% of the premature ovarian failure cases are idiopathic. So we remain, as a part of their treatment to diagnose it, to take them till 40 years of age with some amount of help with the hormones, and to prevent their lack of estrogen symptoms and the long-term diseases in them. So POF is associated with the long-term risk and decreased quality of life. Estrogen therapy reduces some of the consequences and should be offered to the woman till the age of natural menopause. Use of MHT reduces the long-term risk of the cardiovascular diseases, osteoporosis, affective disorders, and dementia. With women delaying pregnancies, poor ovarian reserve, POF, leading to infertility is on rise. It is important to detect declining ovarian reserve before the POF sets in. Preventive action is fertility preservation, and it is essential while treating the childhood cancers, AML and all, and while during the pelvic surgeries. Fertility preservation options should be evaluated, discussed with all young patients undergoing the cancer therapy and desiring future child. ERT with oocyte frozen in the younger age is definitive therapeutic intervention in women who delay their pregnancies or in the women with poor ovarian reserve at younger age. So let's create a smile to all these girls who have, lost their ovary quite early. Thank you for the patient listening.
Thank you indeed, Dr. Veena, for a comprehensive look at premature ovarian insufficiency. And indeed, yes, over the years, our understanding has changed, and we have a lot of tests in our armamentarium by which we can give a diagnosis. But finally, the treatment has not really changed, isn't it? Because we can only counsel them and give a prognosis and give them options for the problem that they have, whether it is vasomotor symptoms, or whether it's a fertility issue, or whether, as you spoke of, malignancies and things like that, we can offer fertility preservation to all these women. And of course, sometimes viral oophorytis is a very sad thing to happen, because nothing we can do, we just have to treat them symptomatically, and the things are absolutely ovary gets destroyed, and only replacement is what we have to do. So hormone replacement therapy becomes the mainstay of treatment for premature ovarian insufficiency, along with all that we have already said. So thank you, Dr. Veena, for giving us a comprehensive take on premature ovarian insufficiency.
Thank you so much, ma'am, for your kind words.
Asha, can I
I don't know if there are any questions
Yes,
in the
ma'am.
chat box.
Please go ahead.
Are there
Asha,
any
yeah,
questions?
one point is there. Venus has covered, I think, exhaustively everything, starting from etiology to treatment and everything. One thing is that 10% of the patients, I'm coming out of my bedroom actually, 10% of the patients, they revert back. So that is what she said. Now, how do we tell the patient how long to wait? So that is the question. She has come to you, maybe amenorrhea, maybe irregular periods or something, and says she can revert back. So that is the question is for how long we should wait before telling her, now we have to do the proper treatment. So the answer to that is 6 months.
Yes.
We have to wait for 6 months. And if she doesn't come back to normal within 6 months, then she is already into premature ovarian failure. And then we have to, depending upon what she needs, whether she needs the hormone therapy or she needs the infertility treatment, or she's continuing with her oncology treatment, which is causing her vaginal problems and all that. So depending upon her need, then we will be treating her. So 6 months is the time which we can give her for reverting back.
Very true, ma'am. And what happens, it's not an easy diagnosis to imbibe also. And the mind and the thought process is so dynamic in these young girls that you have to, wait for
So that's a very
definitely for the
psychological.
diagnosis.
You have covered that.
Yeah.
Yeah, but in practice, we say 6 months, but I have seen patients at the age of 40, 41, they, come with an amenorrhea of 1 year or 1.5 years, and suddenly they start getting periods and they're having very regular periods. So the question becomes, you treat them as postmenopausal bleeding or what it is. So I guess we have to individualize and look at each person individually. Suddenly, it's very, very difficult to explain as to why this has happened. Otherwise, there are normal women who have had children, but suddenly, whether it's some viral infection or whether it was some vaccination, something which has caused a little bit of an autoimmune problem, which reverts back to normal and they start getting their periods. So, as I said, whether it is 6 months or 1 year, I think, depending on the age, we have to decide. If she were
yeah, we can do
Yes.
our own study. Why don't we, infertility specialists, look after these patients after how
Yeah.
many times they have come back? We can do our smaller studies also and have our own data, because premature is becoming, as Vinay said, very common. I don't think it's the 1% incidence now. It's much more than that. Maybe tuberculosis is causing, maybe early hormone, environmental factors. Yeah, I believe in environmental factors. Pollution is a big challenge for all of us.
Just last week, I saw this 39-year-old who had
Yes.
1 year of amenorrhea. Of course, she was abroad and she saw somebody, but then she has come back here and she's having now regular periods. And last month, she came to me for a prolonged bleeding. So it becomes very difficult she's otherwise a thyroid. One is thyroid status and weight gain, weight gain. If they lose weight and all that, the hormonal whatever milieu gets altered and they start getting their periods. And the hypothyroid state, if it gets corrected, again, sometimes they start getting periods. Everything is so interrelated. So it's very, very important to evaluate each person, differently.
Yeah, it is interrelated, Shubha. I completely agree with you, because that is why I'm always talking about holistic health of women. It's a
Yes.
holistic health of women. We just cannot divide her into compartments. So that is very
Correct.
important. I think, thank you, Venus. She has been wonderful.
And one thing I can say is, if there's a period of amenorrhea and if you have done FSH and that is not high, it is somewhere borderline or it is in the normal range, then we can expect the ovarian function to return. But if FSH is high, then it doesn't happen.
Yes, excellent. I was going to mention that only. Ki hormonal assay, perhaps we have to repeat to see. And the period bleeding, excessive bleeding can be there because she had a period of amenorrhea when the endometrium was building up. So when she
Building up.
started, building up. So that's why she had more bleeding after that.
Yes.
May I add something in the same lines, Dr. Shubha? Similarly, as you said, for FSH, if the FSH is coming more than 10 at the time, we should be in a position to caution the patient also that she might be going towards ovarian, both ways. If it's less,
Correct.
okay, we are complacent. But if it is coming to be more than 10, we should be giving her some kind of warning so that at least some lifestyle modifications can be done to delay the
Correct.
premature.
Very true.
Any of my experts wants to say anything more before we end the session and start the panel?
I was just reading, Dr. Asha, that there is some village in Andhra Pradesh where there is rampant hysterectomy and bilateral salpingo oophorectomy, and average age is 28.5 years.
Yes, this was
Yes,
there.
ma'am.
So before
This news
30
was
years,
there in the media. Yeah.
Yes. And so, I mean, we have to stop this. We have to look into this, that why we are doing these rampant hysterectomies. 28.5, we can, I mean, what iatrogenic POF we have given to the...
Even Maharashtra has an area, ma'am, where the
Yes.
hysterectomies are happening early because the lady don't want to lose their work days, and they lose on their work days when they are menstruating. So they just get their hysterectomy done as soon as their pregnancies and the number of the babies desired are completed. So there are many practices that are, going on. So what hurts me most is when young girl with simple follicular cyst diagnosed and the whole ovary sacrificed. That is something that hurt as a gynecologist to us.
Dr. Venus, there are two sides to this story. One is that for a simple cyst, a simple salpingo oophorectomy is done, but the same thing is done for a complex ovarian cancer as well. So you have on one side, you have a woman who has unnecessarily lost an ovary, but there is also a very huge group where the ovary has been, a suboptimal surgery for ovarian cancer has been done, and many a time even histopathology has not been done.
Yeah,
that is
so
equally rampant.
So I think this webinar will help at least some group of
Dr. Kunika.
people that way.
Ma'am, many of the surgeries, or I can say maximum surgery of this type, are not done by the gynecologist, number one.
Yes.
And many times they remove the cysts or ovaries just because the recurrence of the cyst happen, and they are not ready to explain that if they operate a cyst, simple cyst, there are chances of recurrence. So to avoid the pain of the patient, they remove the ovaries just like that.
And the good side of the premature ovarian failure is that now we get a genetic diagnosis and we have very good hormonal assays and the ultrasound with high resolution available with us, which was not the case, few years back, but now this is available everywhere.
No, and one more thing I wanted to add was, say a hysterectomy is done for a fibroid uterus, and patient definitely needs, because she cannot afford any other treatment. And then, the doctors will counsel saying that there is a 1% risk of the ovaries developing something later on in life. So that poor lady says that you do something which will not, subject me to some other problem. I don't want to go for checkups and this and that. So the ovaries are removed. So I think it's very, very important that you counsel the patient properly, or at least to keep away some information sometimes for the poor lot of patients, because if you tell them that you can develop cancer 20 years later, naturally she's going to say remove my ovaries at 30. So we doctors also sometimes are to blame, because we are all the time thinking of medical legal aspects and frightening that patient by saying you can have this, you can have that.
I think those who are attending these webinars, they enlightened by this, and they will not under
panel
overly uterus as such. I think these webinars, they are going to help because we have all the opinions from
See, that's
so
all you
unnecessary. They are going to.
they
Thank you,
are
madam.
options.
Unmute yourself, ma'am.
मैम आप ऑडिबल नहीं हो.
Asha ma'am, we are not
Yeah,
able to hear.
thank you. Thank you. What I'm saying is, that it's not just that the gynaec surgeons are doing these things. Everybody is doing them. Either
Yes.
over treatment or under treatment. So let us not shift the blame. And we will try to educate as many people as possible and at least do the right thing ourselves. Thank you so much, Dr. Venus, for that
See, Dr. Asha,
enlightening.
one more point I wanted to add was, as gynecologists, when a young girl comes with a twisted adnexa or a twisted ovary, we have to untwist. Even if it is blue, we have to counsel, leave it there, and then go in and see if there is, a problem again. Because saying that it is blue and it is gangrenous and I want to remove it, there is no proof that it is gangrenous. So we have to untwist, observe, and then only remove that ovary if necessary at a second sitting.
Agreed. And if you don't remove it, then over the weeks, it gradually either it comes back or
Yes.
it dehydrates. Like you do a fetal reduction, you're not removing it per se, right? Most of the
Correct.
time, if it's done early, it gets absorbed. So you may not have to go for the second surgery later.
Yes.
So let us start with this tribute to my Guru Swami Ranganathananji Maharaj. Whatever you do, do it excellently. Excellence in work, excellence in interhuman relations, excellence when none is watching you. Such excellence will come only when you are not enslaved and experience true freedom and dignity. So let us have that dignity and provide it to our patients. And we proceed now with the panel. I would request everyone who is currently logged in, if they have the time, to remain logged in. So I would introduce Dr. Ruche Bhargava ma'am, who's the director of Bhargav Advanced Gynec Surgery and Cancer Center. She is consultant and she is the past secretary of Jalandhar Society, chairperson academics, Jalandhar Society, patron PCOS Society, and faculty at national and international conferences. She is the one person who has helped me put this webinar together. She helped me with everything, with the speakers, with the panelists, and she's been like a backbone to my programs. So thank you so much, Dr. Ruche, for being here again with me and sparing your valuable time.
It's a pleasure to be with you always, Dr. Asha.
We have Dr. Kiran Chandna ma'am. She is the president of Faridabad Obstetric Gynec Society. She's another one person. She's in the UK right now, but still she helped me get panelists and agreed to participate herself. She's a member of the FOXY MTP committee, special interest in adolescent health and contraception, and has an experience of 35 years. Hope to see her in FOXY soon. We have Dr. Alka Yadav ma'am, another dear friend, consultant gynecologist at Shanti Hospital, Narnaul. She is the president of Rewadi Society, member of FOXY Public Awareness Committee, member of District Medico Legal Committee, VP IMA Narnaul, chairperson, WVW Narnaul Best Paper Award twice, and is a regular attendee as faculty for conferences. We have Dr. Kunika Chechi ma'am, who's the gynecologist and IVF specialist, director at Vardhan Nursing Home and IVF Center. She has the credit of the first IVF Bedi in Palwal. She is also the president of Palwal Society. Dr. Shraddha Aggarwal, founder and past president of Palwal Society, Haryana member of the Breast Committee 2019 to 21. Another extremely enthusiastic friend that I made on webinars, who is always helpful and ready to join. I have Dr. Mini Bedi ma'am, professor obstetric and gynecology. She is connected to Adesh Institute of Medical Sciences and Research, Bhatinda. Her areas of interest are high-risk pregnancy, fetal medicine, and minimal access surgery. She is the founder secretary of Bhatinda Menopause Society, member of Foxy Amasi, has many publications, and is a reviewer of many journals. Dr. Gitanjali Kaur, ma'am, a gynecologist and obstetrician, MD from PGI Chandigarh. She is a life member of Society of Fetal Medicine, executive member of Ludhiana Gynec Society, life member of Indian Menopause Society, life member Logs, and life member of North Zone of Foxy. Welcome, Dr. Gitanjali. We spent some nice time in Spain. And with this, I start the panel. So these are things that you have all read. So I will directly go to the questions. And so these are the introductory questions. I have not allotted questions to anyone, so everybody is free to answer on their own. What are the common etiologies of premature ovarian failure, and how can they be differentiated? How do you actually differentiate one etiology from the other?
Yes, ma'am. Most common etiology of the premature ovarian failures are like genetic causes.
Dr. Shraddha, would you be a bit louder, please?
Yeah.
A little closer to your system.
Can you hear me now, ma'am?
Yes, please.
Yeah. So genetic causes are the ones we most commonly come across. Then comes the environmental causes, iatrogenic causes, metabolic causes, and some hormonal causes, and the infections like TB, mumps, and cytomegalovirus, Shigella. So there are different etiologies, but most common etiologies, like most common cause, like Dr. Venus said, it is idiopathic. 62% it accounts for.
So the causes that we already know, how are you going to differentiate them?
So we can differentiate the causes by doing different investigations like hormonal evaluations, ultrasound, and taking the family history. Also going for the examination of the patient, like calculating the BMI and looking for the metabolic causes. Also taking the past history of thyroid hormones like hypothyroidism.
So now I would like to ask Kiran ma'am that will you do a genetic study on every patient, or there are certain class of patients where you want to go ahead and do the genetics?
If we will take the proper family history of such patients, if they have some family history of premature ovarian failure, premature menopause in the family's mother, or aunt, or sister, if they have low fertility and decreased and low age of menopause, then these are the patients, and especially if some of the patients they have got some male member who has ataxia or mental illness. That may be attributed due to the some genetic that may be associated with the premature ovarian failure also, or the chromosomal anomalies also, because the male members they are affected by these members by this mental illness, and usually the females they have the premature ovarian failure in such cases, and so there's a lot of role of family history and genetics also in the premature ovarian.
Young babies, ma'am.
Can I add something?
Like young patients, especially in young patients and patients with family history.
Can
We'll
I
go
add
for
some?
genetic testing.
Yes, ma'am, we will like to
Ruchi,
hear.
please go ahead.
Yeah. If and apparently, the phenotype like internals, the look gives you the diagnosis. So where apparently there is a syndromic look is there, those patients you can go, especially you must go in those patients for genetics.
Yeah, so that was the point I wanted to bring up, that the phenotype will give you the clue most of the time. If the
Doesn't
phenotype is something abnormal, there is some syndrome, then you know what to test for. Otherwise, it's a black box. What are you actually going to test for?
And
So,
even like for Perrault syndrome, Dr. Asha, like sensory
yes.
neural deafness, the patient is giving you a history. So that history itself is pointing towards something. So those cases you go on for genetic studies.
Okay, so the phenotype, the other symptoms that are already associated will tell us what test to do, right? So now, once that is done, this is just a recap of what Dr. Venus has already said. So what hormones are you going to test for this patient? What are the hormonal tests that you're going to do?
So, like
First
FSH.
and the foremost is the FSH we will be testing, but then the thyroid hormone is also essential in these patients. You have to be testing about the hypothyroidism factor and the anti-TPO antibodies. They are also important. And then we can go for estrogen in these patients. AMH is a good indicator. The first and the foremost is the FSH levels you have to see. The cycle, history of these cycles which the patient is giving, whether she is missing 1 or 2 cycles or whether she is having prolonged cycles. So accordingly, we have to go for FSH, or we have to go for thyroid antibodies or AMH and USG. That was the first one. So that is non-hormonal test, but for the hormones, these 3 are important: AMH, FSH, and thyroid hormones.
And estrogen.
Estrogen, estrogen levels are also important in these patients.
Yes, that is true, ma'am. And does anyone have experience of inhibin B?
we are getting inhibin B done.
No,
Inhibin B, ma'am, we have not gone for
we have
it.
not got done.
No, in any
We have
case.
not, we are not getting it done, but this test is available because it has been seen that both inhibin A and inhibin B levels are low in patients of POF. So this inhibin B test is available with some labs in some cities. You can go ahead.
Okay.
What about insulin resistance? Are we doing it nowadays? Serum insulin?
Mostly in cases of PCOS, we are getting it done, not in cases of POF. But personally have not got it done in POF cases.
So what are the long-term health consequences of POF in women? About cardiovascular and bone health, because Dr. Venus said that you have to give medicine to protect the bone and the heart. As far as I know, does hormonal replacement have any effect on cardiovascular health?
Definitely, the level of the estrogen we are maintaining with the HRT will be cardioprotective in these cases, because post-menopausal, the decreasing level of estrogen are the major cause of cardiac risk in patients, post-menopausal patients. So patients with POF are definitely at an increased risk of cardiovascular diseases, and this can definitely be prevented with the HRT.
Ma'am, there is a lot of contradictory evidence about that whether HRT has any role in prevention of cardiovascular disease. And that is why I asked this question, that if you are giving...
if it is early, then it can be effective. If it is started late, above the age of 60, then it is not that effective.
No, ma'am. Here I'm talking about a girl who has premature menopause at the age of 20 years. She's had... Then will she have even a girl of primary amenorrhea? She has never had her period, but actually her ovaries are non-functional. So she is technically also in POF. So do you think giving her estrogen and progesterone will be cardioprotective? That is my question.
I don't think there is any harm in giving HRT in such a young girl, and it will definitely be
Ma'am,
cardioprotective.
my question is very specific. It is useful because it will give her secondary sexual characteristics. It will
Yeah.
reduce her genitourinary symptoms.
But
But
then
will it be effective for protecting her heart? The question is just the heart. It will protect the bones as well. But will it protect the heart?
It's not like we have to individualize the patient, and we don't have to give this HRT for a long time. Then it will
Ma'am,
be
this
effective.
for
If we are
premature
giving-
menopause, you will give it till the age of natural menopause.
Yes.
That is approximately up to 45 to 50 years of age. So it will be at least 20, 25, 30 years. So that is the question that we actually need to study. We need to study that if you give it, is it
There are not
cardioprotective?
much studies on this cardioprotective action, but what previously we have been studying about the hormone replacement therapy is that it is always effective. But recently, they are coming up that it is not very helpful.
Yeah,
Because mostly
Ma'am, we
the
just had a
patients-
webinar with IMS, which was last Thursday, where we had a cardiovascular physician with us, and he said it very clearly that any amount of hormone is not cardioprotective because what you are giving is not the natural hormone. And then a hormone to be active, there are multiple things. Whether it's going to act on the receptors, what is the absorption, what is the activation pathway. It's very, very complex, but he was very clear that it does not protect from cardiovascular disease. Bone health, yes, but he said it. And I think we as gynecologists need to correct more data on that.
Yes, sir.
Dr. Asha, here I would just
Yes,
like
ma'am.
to add that when we are giving this replacement therapy, we are not giving it for protection of the heart.
Exactly.
We are hypoestrogenism, that is the cause, and that is why we are treating that. So we are not actually giving it for cardio protection. So
that is what what I said. That we are not giving it for cardio protection, but somewhere we have it that we have replaced it, so the effect on the heart will be there. The heart will be safe, but it doesn't happen. The heart has to be cared for separately.
Only
yes,
the
Dr.
nice
Kiran.
thing, yes,
Dr. Kiran, you wanted to say something?
Lifestyle, I think for every patient, we should have lifestyle management. Cigarette smoking in such patients should be avoided. Alcohol intake should be avoided, and caffeine intake should be avoided. They should have proper exercise. For such they should not gain weight. And these are the pollution, environmental pollution should be avoided, should be reduced. And these are the measures I think they are going to help.
Exposure to radiation, that is also
Yes.
very important. But as far as possible, it should be avoided, basically.
Okay. So now, Dr. Kunika, I come to you.
Yes.
What treatments are available if a woman with POF is coming for fertility treatment?
When a patient comes for the fertility treatment, we need to the duration of infertility and the other causes associated or not. And if other features are okay, we can try for ovulation induction and IUI, and if not successful, can go for IVF and may go for ovum donation. Actually, the with ovum donation.
Okay. Alka ma'am, you would like to add something here?
Actually, we have to first see that whether the patient is having this thing natural ovulation or not, because in almost 20 to 25% cases we'll be finding that natural ovulation is occurring. So if it is all right, if the patient is ovulating by itself, so then we need to follow this follicle and promote the patient for natural conception. And in the patients who are not ovulating, there we have to go for the ovulation induction, basically. And for that, we have to first see for the antral follicle count and the AMH levels, I think. That is more important.
So, Dr. Shraddha, would you like to add what is new that we have? Anything about PRP or anything? Any new thing in?
Like PRP can be done, ma'am, and we can also give this mitochondrial replacement therapy, ovarian, and also we can give the stem cell therapy. And
So,
it is called mesenchymal replacement, stem cell replacement therapy. So that is to accelerate the possible activation of DNA damage repair, and also this coenzyme Q10, melatonin, vitamin C, E, they can be added to the treatment. The personal experience of subcutaneous growth hormone I don't have, how to monitor those patients, and I really want to ask someone who has experience of giving growth hormone subcutaneously in this patient.
Some of the endocrinologists for those patients who have got stunted growth, they give therefore to reduce growth hormones.
Like in Turner syndrome, the
Maybe
patient
because that they
Turner
are
syndrome or
one of my
some
patients.
Fragile X syndrome.
One of the
What is the effect of growth hormone replacement therapy?
You need to take the help of an endocrinologist here, and they would prescribe, but you always have to remember that if the epiphysis has fused, then nothing is going to have an effect.
Yeah.
So that all that effect will be only if you suspect something is wrong and start it around the age of 7 to 8 years. Then it is effective. Otherwise, it doesn't work.
I had one patient, such patient, who was then referred to the endocrinologist. They did the X-ray of the wrist also, and then they started at the age of 8 or 9 years. They started growth hormone patient for 2 years. They had given to that patient, and in the meanwhile, the growth of that patient, in height of that patient, that increased, and after that she attained menarche. That was my personal experience.
That is great. Yeah.
That is almost a daily injection, subcutaneous wala. I've not had the experience, but that is a daily dose which has to be given.
It's a daily dose. I had one patient, Jisko, she came to me when she was 8 years old.
Okay.
And then she continued the treatment for 3 years. Now she's okay.
Can I add
At the
something?
outset of puberty, basically,
Yes, Dr.
Ruche. In these cases?
Okay, so you hear it firsthand from me. My son had stunted growth, and he was an IUGR 35-weeker, 900-grammer baby. And we all thought, "Wohi jaise hota hai, he's weak, he's weak, he's weak." But when we started seeing the children in his class, they were growing taller, and he still remained a lanky-panky young child. We visited a pediatric endocrinologist. And that's when he did his x-rays, and he said his bones epiphyses have not fused, so let's give him growth hormone. Madam, I have given it to him for 5 years. Everyday injection, subcutaneous. I taught him to take it himself, and he has attained what growth he should have achieved at his age now. He's in his third professional MBBS now. So it's a very first-hand experience that it's a wonderful thing for those who use it.
Nice.
But the beauty is it should be diagnosed early.
Yes.
It should be diagnosed early and started in time.
Yes, we were a little late because I think that's it. As doctors, we were not very good parents. We should have paid attention a little earlier.
Endocrinologists say that at the onset of puberty, basically the patient should be evaluated and accordingly the hormones should be managed.
as I said, we missed it. We missed the bus a little, but still we were able to get that advantage so that he's reached his average height, what it should have been.
So now, thanks for sharing that, Dr. Ruchi. I know it's not easy to share something personal.
Yes, yeah, really.
But
Thank you.
that's when patients come to us and ask about whether we should give hormones. So I'm in a position to tell them that, yes, please go ahead with it. I've seen it myself, so I am going to encourage you for it.
So if somebody has autoimmune involvement, does that patient, like Hashimoto's or something like that, does the management of POF differ in such a patient, or the management remains the same?
If the OSA, this thing AMH is low and the patient is not ovulating by herself, then I think she should go for oocyte donation. Basically, that is the best thing which can happen to the patient.
No, here we are not talking of fertility. We are just talking how do we manage this patient. The management, is it just estrogen, progesterone, or you want to manage her autoimmune status as well?
Yeah,
and you think
like
if you manage the autoimmunity, the POF will take care of itself. What is the opinion of the experts here?
Like anti-TPO antibodies can be done in case of Hashimoto's thyroiditis, and if you find that antibodies levels are high, then we should speed up our treatment, or we should think fast in that woman. We should go for cryopreservation of the oocytes, and if the partner is present, then cryopreservation of embryos as well. So we should actually hurry up when we see that antibodies.
So if you see autoimmune disease, be aware that this may lead to POF.
Yes.
So save her ovaries, save her ovum, or save her embryo, whatever, as the situation is. But how are you actually going to manage that autoimmune disease? If it is thyroiditis, as far as I know, there is no specific treatment for it.
Yeah.
It is only the hormonal level you have to keep on getting it checked at regular intervals, because these patients tend to go into hypo and hyper both, and at times they are normal also. So we have to be just dealing with their thyroid status, that they have to get it checked, and if the symptoms are there, so they have to get it checked frequently. But for POF, if the cycles are very irregular, or then only we should go for this thing, hormonal intervention to these.
We can give corticosteroids also, ma'am, in case of thyroid. I mean autoimmune status.
Let me ask. I would like to take the opinion of everyone.
Then,
ma'am, steroids, yes or no?
Ma'am, prednisolone should be given guarded, because it can cause the Cushing syndrome also. So, and the gonadotropin therapy it is not advisable, because it can exacerbate the autoimmune premature ovarian.
Endocrinologists do not prefer this thing prednisolone, this steroids directly for Hashimoto's. They do not recommend it.
Kunika ma'am?
Ma'am, I will prefer to give steroids short term just for the treatment for IVF or pregnancy, but not long.
Okay.
But that is mostly, I think, partly in a cycle you must be giving, Dr. Kunika, not a prolonged one.
Ma'am, not a prolonged one, but in case of autoimmune diseases, steroids are of help when we are doing the treatment of the patient. We want her to conceive early, we want to help her, and we want to reduce that autoimmune status of the patient. Dr. Kunika, you can unmute yourself. Unmute, please.
No, she has muted. Yeah. Ruchi ma'am, the final word, we come to you.
I think in certain cases of autoimmune diseases, I will agree with Dr. Shraddha that you have to give steroids. When there are flare-ups, you have, again, I will again be in line with Dr. Alka that they are not long-term treatment protocols. They are not favored for that. But yes, sometimes वो कहते हैं ना कि कुछ भी काम करे, कुछ तो देखो शायद कुछ काम कर जाए. So sometimes in some certain cases you have to give them steroids.
So now we come to the cases, and the first case that we have is a 28-year-old lady. She presents with secondary amenorrhea for 6 months. Her mother had early menopause. Her Masi also had an early menopause. She has elevated FSH, low estradiol. So do you want to do genetic testing?
Yes.
What are you going to test her for?
So we can test her for karyotype first, like to rule out the XO or XX or 46 trisomy, and also to look for Turner mosaic, and also for some gene deletions.
Okay.
So whole exome sequencing is of very much help nowadays in these cases.
Why do you want to do whole exome? Her mother is there, Masi is there. The index cases are already there. She's also there. So we already know that all the genes for POF are on the X chromosome. So a clinical exome would make more sense rather than going for a whole exome. Don't you think so?
Okay. Yes.
I'm just asking the opinion of everyone. Means it would be a whole instead of a whole exome, you know which chromosomes the abnormality is sitting on.
Yes, that will be better instead of going for the whole, because when the history is so much indicative, a family history of POF is also important. So if it is there, so we can go for a selective examination only.
So you would do that. And now how are you going to counsel her? She has 3 daughters. Okay. So how are you going to counsel her about the risk of POF in her girls? Telling somebody these days कि बच्चे की शादी जल्दी कर देना is very difficult. Very. So how are you going to counsel this patient?
मैम को काउंसलिंग तो करना पड़ेगा कि जल्दी मैरिज करना जरूरी है, और इसके साथ साथ अगर वो कुछ नहीं करना चाहेंगे तो वी कैन थिंक फॉर प्रिजर्वेशन ऑफ ओवरीज to avoid the factors which can reduce the reserve of the ovary, like alcohol, smoking, and other.
You've done her clinical exome. You know the genes responsible. A girl has 2X, right? So
Yes.
do you think you want to test the daughters for the abnormal gene, or you just want to give a blanket advice?
And we will check and confirm. After that, we will advise.
Anybody wants to differ on that? What are you going to advise and when? Alka ma'am?
Actually, the thing is you have to see the background of the patient. If they are ready to accept what it is, then you can go for a specific counseling. Otherwise, you have to give a blanket counseling for these patients.
But the girls may be absolutely normal as well. Right?
Yeah, so it has to be a blanket advice that this thing may turn up for them. Not exactly. And we have to be advising them if at all she develops any menstrual irregularities or any problem with that, so then she can go for we can go for her this thing, AMH and AFC levels, and FSH levels. If they develop menstrual problems, then only we can. So we have to give that blanket counseling only. That is important.
Kiran ma'am, would you differ on that or you agree with that?
We have to see what is the height of the patient, what is the physique of that patient, if there is any symptom of...
No ma'am, you have her genes. She has a genetic problem. It is on her X chromosome. So I'm asking you, she has 3 daughters. What will you advise for her daughters?
We can do the genetic karyotyping of that girl.
Dr.
If they have-
Shraddha?
Ma'am, we have to tell her that there are 50% chances of her daughters getting the same thing, and we have to tell her that she has to be cautious if they develop some menstrual irregularities, or they develop amenorrhea,
So
or
you are basically saying the same thing that Dr. Alka said. Nobody
Yes.
wants to counsel the patient to get her daughters tested.
Yes.
that
Means
is
I
what
would personally want her
we can
daughters
have to
tested before
Tested.
I say anything else.
I wanted to
Dr.
tell you
Asha,
that.
I would like to
Correct.
share one case. Actually, I have had a similar case with me, the mother and her sister basically. There were two sisters and उनकी मम्मी और मासी को दोनों को same चीज थी. POF was diagnosed earlier और वो one of the daughters was IVF also. तो मैंने उनको इसी तरीके से जो है उनको काउंसिल करने की, दैट वाज सम 5-10 इयर्स बैक, मैंने उनको काउंसिल करने की कोशिश की कि जब आप लोगों में प्रॉब्लम है तो डॉटर्स में भी आ सकती है. तो वो जैसे कहते हैं ना, एकदम भड़क गए, नहीं ऐसे नहीं हो सकता. तो मैंने कहा कोई बात नहीं, यू हैव टू एक्सेप्ट इट. आप इसको एक्सेप्ट करो या नहीं करो, दैट इज योर पॉइंट ऑफ व्यू. तो वो पर लेटर ऑन 2 साल के बाद में जो बड़ी बच्ची थी, शी वाज आई थिंक 16 और 17 इयर्स ओल्ड, तो उसको 2 साल पूरे ढंग से पीरियड्स आए और उसके बाद में उसके 2 साल के बाद उसके पीरियड्स एकदम से ऑल ऑफ अ सडन 2-3 months
Ma'am,
के
that
मेनोरिया
is
पे.
what you are saying here is what you should say to the patient, I think. And if we counsel them comfortably, showing them data. 10 years back, we did not have so much data. 10 years back, we also did not know so many genes. Today, we know all that. That
Yes.
information is new. So we can always, if we are motivated enough, 99% times we will be able to convince the patient. So here I would actually request everyone to at least try to talk to the patient to convince her daughters. Means first get herself tested and then test the kids only for that. It would be much less expensive. It would not be a whole exome or anything. Maybe a fish could do the trick. So,
Yeah.
then it would
Some
be
genetic testing.
some genetic
Definitely today
testing.
we are in a better position.
Today
Yeah,
we are in
definitely.
a
I agree.
much better position. There are many companies doing it. There is a lot of competition. You can get it done for less as well.
yes.
See where NIPT has come. You get NIPT at 6,000 today.
Right.
It
Yeah.
was
Yeah,
in-
yeah,
it
definitely.
was 30,000 something. So today time has changed and we sort of need to adapt to it is what I think. Now you have tested the daughter and you find that she has genes of POF. Now, this is really catching her early. What are you going to advise at this point?
Now they need to be counseled for an early marriage. The mother should be counseled for that, and the daughters also, that they need to have an early marriage. Or if not that, then they should.
Yes.
Oocyte preservation can be done, or
Site
the
preservation should be
Oocyte
done.
preservation, yes.
Now, oocyte preservation has been done, but I'm asking you, in those oocytes, they would have that same genetic mutation, right?
Yes.
Possibly, yes.
mitochondrial replacement therapy.
So then what would you suggest? You would, if she's done that oocyte preservation, बहुत सारा egg रख दिया, सब रख दिया. So now what next?
Oocyte
Prenatal
donation.
genetic testing.
PGT, man. Whenever she goes for
Whenever she goes
procedure.
for, yeah. So whenever she goes for childbearing, she would require that PGT as well, which has to be, sort of mentioned somewhere on your paper to make it clear. You may not explain everything, but at least it should be there on your paper that these are the consequences. Now, this patient who has had menopause at 28, will she benefit by hormonal replacement? Dr. Mini Bedi has joined. Welcome, Dr. Mini.
Thank you so much, ma'am. I'm sorry, got stuck in an emergency OT. Just
No,
got free right now.
that's fine. But you are here now, and we are
I'm
just
sorry
at the
to
first
wait.
case.
Okay,
So,
that's great. That's great.
so this patient, she has had premature menopause. Will you give her HRT, and what is the dose that you're going to give? Dr. Venus explained 3 options. I want your personal choice. What would you like to give? Because the dose of HRT in the, 50 plus menopausal woman is different from that of a young patient. So what are you going to advise her? Dr. Kiran?
I think the dose should be slightly higher in such cases.
Ma'am, what are you going to advise her?
We can give them the combined oral contraceptives, combined estrogen plus progesterone.
Okay, you suggest giving her OCPs. Alka ma'am, what would you like to give here?
Combination pills are definitely better for these patients. The estrogen and progesterone combinations, they should be given in cyclical therapy.
Kunika ma'am?
And I will prefer estrogen followed by progesterone for 14 days.
Yes,
Okay.
the same thing what I'm telling. Estrogen and then the
Which estrogen do
progesterone in
you
the later
want to
half.
give? Which estrogen do you want to give?
Estradiol.
Okay, or you want to give equine estrogen?
And I'm not using that.
Actually, we used to give equine estrogen conjugated, like 0.625 milligram. I have given to so many patients, and they have got the menstrual cycles also with that.
Yeah.
But nowadays, like transdermal estrogen patches are in use. I don't know whether we are getting it here because I have not used for any patient, but they say they are in use in UK. So transdermal 17 beta estradiol patches are available. Those can be given to the young
Your
girls.
young patients who are 28, 29, or even younger, or less than 40, when you are keeping them on hormonal replacement, do you want them to have periods or not?
No, we don't want to have them periods because we want to preserve those.
May I add something? These patients, we want periods.
Okay.
So and earlier, as we all said, that we were all using conjugated equine estrogens were being used. But now we have better formulations with lesser side effects. They are a little costly, no doubt, but they have fantastic results. So if a patient can afford, then it is better to give combinations of estradiol valeriate plus something like dydrogesterone or something. They're
like
little pocket unfriendly, but very patient friendly. And as ma'am said, this kind of a patient, she's young, she would like to have periods. She's already upset with the disease. Now we cannot put her into more amenorrhea. We have to make her, at least psychologically, she has to be feeling that she's having her periods. So you have to give them that break. It's not a continuous regimen that you give them an amenorrhea. This group, you don't give them an amenorrhea.
And one more thing is that she has a uterus intact.
Yes.
So if you are giving estrogen and progesterone, then you want at least 4 periods in a year.
In a year.
Otherwise, if it is less than that, the chances of carcinoma, endometrium are really high. And because she already has a genetic disease, you actually, aging is accelerated. Because aging is accelerated, the diseases of old age can come up earlier. Therefore, you really want her to have at least 4 periods in a year. If she wants more, she can have more, but you want at least those 4 periods a year.
And here, since we are talking with POF, the amount of estradiol valeriate that we are giving has to be more. I mean, if we are giving after 40, we can give 1 milligram, but if we are giving before 40, we might as well give it as 2 milligram because she needs a higher dose at this time.
you might have to give even more than that, because I have had patients where I have been giving this for years. So 1.2 milligram equine estrogen and even 6 milligram of estradiol has to be given at times when these patients present to you as primary amenorrhea. They have taken 2 milligram and nothing has happened.
That is what even I wanted to add, ma'am.
I've
Same
never had
thing
the chance
happens.
to use more than 4 milligram in a patient.
I have given.
But we need to individualize, ma'am. In fact, usually we start with a low dose, but yes, we may have to increase the dose with the further cycle, with the next cycle, if the patient doesn't get a period. And getting period is very much physiological, like psychologically for the patient. So there's no harm if she gets a period. It is in fact good for her. Although she needs to be educated that there is no ovulation. She's not ovulating and getting periods. This is all only because of the drugs that she's getting periods.
So we proceed to the second, and this I think we had actually done quite a bit of it in the general question. So we go to question number 3. So this is a chemotherapy induced POF. 25-year-old lady completed chemotherapy for Hodgkin's lymphoma. 3 months after treatment is completed, she comes with amenorrhea. FSH is high, estradiol is low. Now what are you going to do? And what should have been done? Because she was diagnosed as Hodgkin's lymphoma, so what should have been done?
So, cryopreservation of oocytes must have been done before starting the chemotherapy.
For GnRH analogs, they should have been given before the chemotherapy.
Okay. And should her ovarian function have been tested before we proceed for Hodgkin's treatment?
Yes.
That should have been done.
AMH
That
and
is important.
the AFC count.
Yeah, but even if it was very high, you know, everything was normal. Even then, if she has received a full dose of chemotherapy for 6 months for Hodgkin's, it would actually kill all that is present. So would that alter if she had a poor reserve or she had a good reserve? Would that alter the treatment?
Not exactly.
No.
Treatment will depend on the condition what she has presently after chemotherapy. What are her hormone levels? The treatment is basically dependent on that.
So what are the options for fertility preservation? One is cryopreservation. One is GnRH. What else?
If the oocytes are good, then these treatment will work. If not, then oocyte donation is the treatment for her.
Donor oocytes, yes.
Donor oocytes.
And if partner is present, then obviously the embryos.
Now she has had cancer. It's a Hodgkin's. So would you give her HRT? She has now POF at the age of 25 years. Would you give her hormonal replacement?
Not recommended.
Ma'am, think again.
Ma'am, not straight away, no. It is not like that. But instead, estrogen receptor modulators can be used rather than using direct estrogens. Okay.
Some immunomodulating.
It's a Hodgkin's lymphoma, right? It's a Hodgkin's lymphoma. It is not a hormonal dependent.
It is not an estrogen dependent tumor. I mean, we can
So
use,
then
but
why cannot you give HRT?
HRT, yes.
See, if it is a hormone dependent tumor, any tumor anywhere in the body, and it's hormone dependent, then you're going to think about giving HRT. But if not, then what's the harm? Ruchi ma'am?
I think this patient should be given there is no harm because Hodgkin's lymphoma, as you said, is not hormone dependent. Now, the only fear, Dr. Asha, I think, is when you utter the word hormone to the patient, they think they are so paranoid about HR, hormones. The word OCs and hormones, they're very paranoid. So you have to counsel them that this is not a hormone dependent disease. So iske karke aapko nahi hoga, rather whatever amenorrhea you are having now or the ovarian failure, it is going to help you. And obviously, when we give HRT, we have to give patients on follow-up. It's not we write a prescription and then tell them that please don't visit, come after 1 year. So we have to tell them we are going to monitor her. She is going to be on our regular checkup. And God forbid, if there is a problem anytime, we will catch it early. Because okay, if she's got Hodgkin's lymphoma, she is prone to have any other cancer at any other time. She becomes genetically exposed to it, I would say. So we have to keep her on regular follow-up. We have to make her aware of that she's on follow-up. And that is the whole idea of follow-up, that we catch a problem early, if in case it happens. And it is not related to the Hodgkin's, but otherwise, just another coincidence, I would say.
So now we come to the fourth case, which is, this is a patient labeled idiopathic because her karyotype was normal. Do you think a karyotype is enough to label somebody idiopathic?
No, ma'am. There are multiple gene defects which we have searched for.
Yes. So she is a 30-year-old. The karyotype is normal. So what else are you going to advise her?
Fragile X growth.
Microarray or
Whole exome.
Dr. Shraddha, you keep coming back to whole exome.
Yeah.
It has to be a clinical exome, dear.
Clinical exome, yeah.
It has to be a clinical exome. Because if you do a whole exome, you are going to get 50 of unknown significance and you only have a khichdi in your hands. You don't know what to do with it. So the POF panel is what you would advise this patient in her clinical exome. Now, she has this POF and she doesn't have a child. So how are you going to explain? Why me? Mere saath kyun aisa hua? What are you going to say to her? And how are you going to help her with her general health?
Ma'am, what is like POF panel in your opinion?
Med genome, core diagnostic, live cell, they all do it.
POF panel.
Yeah.
Because we have read about a number of genes. That is also like quite a lot.
Yeah, so they do a panel. An exome will do a lot of things. But again, compared to the billions that you have to do, that number is still very small.
Okay.
So whatever we are doing for this patient, can we call it fertility preservation? No.
No.
No. That would have to be done before she got POF, right?
Yes.
So here the bus is already missed.
Fertility preservation is for patients who are at risk of POF.
POF.
Exactly.
Not already who are POF.
Like who are caught earlier with their.
Yeah, so you identify those kind of patients who are at risk of POF. Those patients.
So how are you going to identify them? What are the diseases that are usually associated with POF?
Like hypothyroidism and
autoimmune disorders.
Disorders like metabolic diseases like galactosemia, then infection.
Polycystic ovarian disease, which we see day in and day out. And there's so much of PCOS these days.
Yes. And
now,
so many patients are coming with
all senior consultants. I want to ask you a simple question. It is for my knowledge, there is a girl who is under treatment for infertility. One ovary is having a severe polycystic appearance. The other ovary has a nice dominant follicle. To call it polycystic or not?
No. I will not call it polycystic.
Dr. Kunika, Dr. Kiran. Dr. Kunika, we can't hear you. Dr. Kiran?
Then it is
I would would like to call it a multicystic ovary, Dr. Asha, rather than a polycystic.
It is a proper polycystic ovary. Means it has, as per the guidelines, a volume of 13 cc and it has 32 follicles, antral follicles in it. So as per the definition, it is a proper polycystic ovary, but the other ovary has a nice dominant follicle. So what will you tell the patient? Means this happened with me today in the afternoon. So I'm asking you, what are you going to say to the patient? You have polycystic, you don't have polycystic.
Like the other ovary had dominant follicle of what size, ma'am?
18, 18, 18.
So did
Good
you
luck to Ashil.
Ma'am, did you give a trigger?
I gave a trigger. I gave a trigger.
Yeah, because I would give a trigger. I will not.
I gave a trigger because by chance I saw that. So, chalo. So we proceed now to the next case. I have another case that I want to talk to you about. Should I put it in the middle?
Can I add something, ma'am? Like in this case, if she doesn't conceive by chance in this cycle, and I would like to see this patient on second day of the cycle again.
So you want to do her AFC?
Yes.
And do you want to do FSH, LH, AMH?
Yes.
Okay. So now there's another patient. She has 4 abortions. 1 second trimester abortion, which was done telling the patient that she is going to abort. So, she has a incompetent cervix, so it is better if she aborts. And they did an induced abortion on her. Second baby had a meningomyelocele, was aborted. Then she had 2 missed abortions. Now she comes with an AMH of 0.1. 2 months back was her last missed abortion. AMH is 0.1, but FSH and LH are normal value. So what is this?
You can get it done from Adata lab also. AMH level.
It was done in 3 different places.
We can go for
microarray of the products was done or not?
Nothing was done ever. She had a medical abortion. Twice because of missed. Would you, what kind of genetic study I should do on her? She's a 33-year-old young patient. When I was reading up for this panel, I kept reading everywhere the woman has to be underweight, but she is a BMI of 29. So she's not thin or anything. Normal height, everything normal. So we will talk of it after this case. This is a fragile X and she has premature ovarian failure. What is the connection? For some other reason, we did her karyotyping and it was reported as a fragile X syndrome. So how are you going to explain to her that she might get a problem? What is going to be the content of your counseling? Kunika ma'am, for some reason, we can't hear you. We can't hear you at all. I don't know if you are using speakers or something. If you are using speakers, remove them.
Like computer volume, you can increase. Computer volume.
Ma'am, would you log in again once? Log out and log in again. If you can hear us, Dr. Kunika.
We can see your lips moving, but we cannot hear you.
Okay, I will just leave and
now it's okay.
Now we can hear you.
Yeah. Now we can hear.
Gone again.
Again, the same problem. There seems to be some problem with the connection.
Yeah. So, Alka ma'am, how would you explain the risk to the patient?
Actually,
she
she
is
needs
18, she was underweight and, thin. So her karyotyping was done, reported fragile legs. Now, how are you going to talk to her?
she needs to be explained this thing that there is going to be problem with her fertility, because with so low AMH she cannot have good this thing.
We
Ova.
haven't done her AMH yet. See, she
We
has.
have not done it. Okay.
This patient is a different patient. She has been diagnosed fragile legs.
So, ma'am, we can just investigate her, get her AMH, get one ultrasound done to look for streak ovaries or the number of follicles, because we know that for fragile X pre-mutation, the gene is FMR1 gene, which is responsible, and it is actually associated with the arrest at the primordial follicle stage only.
So we'll have to explain that your fertility is going to be an issue, and if you preserve your eggs, it is good, but even then it will require genetic testing so that it is not transmitted to your offspring. So now we come to the last case. This is a lady who is now 35. She had POF at 30, and for 5 years she's been on HRT. Now she wants fertility. And Dr. Venus was saying that, 20% will have spontaneous ovulation.
Yes.
So how are you going to check whether she has been on hormonal replacement, whether she is having natural ovulation or not?
By doing a transvaginal ultrasound, by monitoring her cycles, ma'am.
But on the pills, will she have that? If you are not giving her cyclical, but you're giving continuous.
Then she will not have ovulation. She will not be ovulating at this time. No?
So then you need to shift her to the cyclical
ones.
So you would have to shift her to the cyclical regime, and then after a couple of months, you start doing a follicle monitoring. Okay.
So,
and how long do you want to wait?
Can you please tell me, like, what is the standard cyclical regime for such patients? Like, as you were telling that you were giving higher dose of estrogen, and
I was giving estrogen continuously for 21 days, accompanied by progesterone in the last 10 days.
Okay.
And when they wanted fertility, I was giving progesterone only for 7 days.
So, ma'am, progesterone like 10 milligram HS or 15 milligram?
10 milligram. 10 milligram.
10 milligram is enough.
10 milligram means my patients have responded to that. And when they wanted fertility, then you started it on day 15, and then you would continue for 14 days. जैसे हम अभी ovulation induction में करते हैं, till you test for her follicular study and all that. But for getting regular periods, for cyclical, I would give 2 milligram TID or 1.2. If she's primary amenorrheic, she doesn't respond to less.
So 1.2 milligram of equine estrogen only?
Yes, yes.
Okay.
So now that she is being given this hormonal replacement, can you add letrozole or its FSH injections or HMG injections to her treatment for ovulation induction? You don't see ovulation happening. So would you add ovulation induction to this regime, or will you replace this regime?
Actually, we can get withdrawal with this regime and induce the patient.
But see, my question is very different. This patient doesn't have insidious estrogen, right?
Yes.
She has ovarian failure. So would you continue with her estrogen progesterone and induce with letrozole or clomiphene or HMG, or would you stop the estrogen you're giving and then do it?
Already because of POF, she is in hypoestrogenemia. So I don't think that estrogen should be withdrawn. She should be given induction on this cyclical regime only.
Dr. Ruchi?
Yes. I think with the same regimen, she should be given gonadotropins. You should not be stopping estrogens.
Stopping estrogens.
Yes. So what gonadotropin and dose would you like to give? What is the maximum that you want to give to this patient? She has limited eggs, so you don't want to actually waste the cycle. So what is the dose that you're going to give her? The dose is not more than 150. More than 150 doesn't work. Either she's going to respond to that 150, 300 is going to just waste her eggs and not get you results.
And will we give her HMG or will we give her only FSH?
You can give only FSH.
Okay.
So, ma'am, can we give a step-up protocol like start with 75 and then go for 150?
Actually, the studies that I read, maybe there are more studies, but what I read was giving only 150, where it's giving results. 300 is giving a lot of side effects, but the results are not so good.
So, for 7 days, is it enough?
There's
You
no
have to
time.
monitor the follicle.
Monitor.
You have to monitor the follicle.
Okay.
So now we are at the end, and now you may go to my question that I had asked about my patient. What do you think I should do for her? Her FSH and LH are absolutely normal, but her AMH is very low. Everywhere they say FSH should be raised. Everywhere they say estrogen should be low, but that's not the case. Her estrogen levels are also 69 something, so they are not poor.
They are not less than 50. So, her AMH is low and she is primary amenorrhea, ma'am?
And before me, no, she had 4 losses. The last loss was 2 months back, and now she has come to me for fertility. And before me, she had gone to somebody who had given her 225 FSH for 10 days. So one ovary is almost ready to burst. It has so many huge follicles in it. So I have given her, what I have done is I've given her OCP for 1 month, for 1 cycle. And I will follow the ovary that is ready to burst again, because it's so tense and tender that I don't know. That is why the FSH, the AMH has come down reactionarily. I actually don't know.
Can leuprolide be given in these cases? Leuprolide depot?
But what for?
How will that help?
Like you said, ma'am, like there are so many follicles and
Yeah, but that was given in her last cycle. After that, she had bleeding for 14, 15 days, thoda, and then free flow.
Then, like, if we induce, like, leuprolide depot will induce amenorrhea for some time, and maybe the FSH will come down with that.
No, but FSH we don't want coming down. No? She has a normal FSH. Her value is 4.
The ovaries, there are too many eggs in the ovary. We want to bring that down, not FSH.
Yeah.
We are just that ovary has become so bulky, as madam is saying. We want to bring that down, not the FSH level.
So now I think we've had a nice discussion. I hope we have all some take-home points for the audience. Requesting, please, one take-home point from each one of you. As usual, Dr. Ruchi, you come last.
Yes, I am happy.
Dr. Shraddha, I start with you.
So, what I feel is we should try to detect these cases at an early stage, and we should always encourage the patients to change to regulate their lifestyle first, And we should always start with the BMI and the basic investigations, and always with the patients with oligomenorrhea and irregular cycles, we should always call them regularly to catch these patients at a early stage, so that we can counsel at an early stage.
Thank you. Thank you. Alka ma'am?
If we detect these patients, then the early diagnosis and early management, that is important, and the main part is the counseling part. The patient has to be counseled, and if she has a genetic factor, so she has to be counseled for that. And if she is having the iatrogenic or the this thing, so the lifestyle modification or less exposure to the iatrogens she is facing, that has to be done. Basically, early detection and early management and counseling, that they are the important part.
Thank you so much. Kiran ma'am?
So, as already said, ma'am, the early diagnosis is very, very important, and we should know that we should not overstimulate such patient. That some of the patient they are giving ovulation induction drugs to in every cycle, and they should not induce for so many cycles, so that the patient does not lose the ovarian reserve. So fertility preservation should be done in small patient, and we should be very careful in management of such cases.
Thank you, ma'am. Mini ma'am, are you still there? Dr. Mini? Dr. Venus? Ruchi ma'am, back to you.
First, I would say we should avoid inadvertent surgeries. We have to really give the best options to the patient before we are jumping into surgery. One. Second is, if you are preserving the ovaries, please make the patient aware that her ovaries are there. If you are removing them, please make the patient aware that the ovaries have been removed. Because as madam said, it is a double-edged sword. If you leave one with a complex cyst and that goes on to become cancer, that is also not acceptable, and you are just removing simple healthy ovaries, that is not also the answer. And we must make use of these fertility preserving techniques that we have. Now we have so many of these Bollywood stars and young girls coming at 28, they have no problem. But because they are not looking at marriage, they are looking at their career. Yesterday only I had a girl, she said, ma'am, I'm not looking at marriage for the next 5 to 7 years. She was already 30. So she said, I want to go for preservation of oocytes. So if we can do this if that awareness level is there, then at least for the patients who are at risk of POI, we should be offering them this. And I think most tier 2 cities, at least, we have these facilities now for preservation of fertility, oocytes, embryo, whatever, what kind. So we must make use of these scientific things, I think, because it's they don't get to use it later.
Stem cell therapy with adipocyte-derived stem cells from stem cells derived from the bone marrow, from stem cells from the menstrual blood are also coming up in a big way. Stem cell and PRP into the ovaries is also giving good results, and it's not very expensive, because those who are doing ovum pickup, they are doing, they are entering the ovary anyway. So PRP into the ovaries is also not a big deal. It's very little expensive. So new things are coming up. We need not feel hopeless, because the problem is we feel hopeless, and we sort of convey that to the patient that now it's the end of the road for you.
Yeah.
So we need to know the newer advances. We need to give her options, because women with POF, the major concern is fertility. That is a major concern when millions of women were interviewed who had this problem. So their first concern was fertility. Second was sexuality and genitourinary symptoms. So these have to be looked after. These can be looked after. What the patient doesn't understand is bone health, which we understand, which is responsible for her longevity. So for bone, we have a lot of options, but we need to look at the fertility part. And if all of us start doing PRP or stem cell therapy from the patient's own cells, I think we are going to lead somewhere good where we will be able to help our women. So Mandar ma'am, आपके सामने इतना बोल रही हूँ. Please, final words from you before I end the session.
Asha, I was there throughout, almost in between. I had to go, but congratulations, Asha. That was wonderfully conducted, especially when you looked into the genetic part. That was very, very important to understand, because genetics is going at a very fast pace now. Technology is going, and we have to keep pace with the technology. And I think POF is something which is being benefited a lot by these new technologies. So it's very, I really felt happy that you had covered all those in case discussion, so that our delegates can also understand, and of course, the panelists can also add so many things in the discussions. So they have become feasible now. Yes, and another branch has come up of the genetics. Wherever we need, we should take their help also, because genetic mutations are also very vast now. Sometimes we cannot interpret those genetic mutations, so we have to take the help of genetics. But please do refer them wherever it is there. It is not only for the cancer, BRCA one we were talking about, because about 10 years back, I took these gynecological cancers and BRCA. Somebody asked me, why you have taken this topic? This is going to be the future discussions topic. So that is where, Asha, you have picked up nicely, and please continue with these series, because lots of work and discussions still have to go on these cases. But especially in a PI where it's not only the fertility, when the people are talking about the fertility, where the societies are there for fertility preservation. So we learn a lot from those societies also. So Asha, what I am saying is that whenever we are doing these webinars, let us do in collaboration. Let us take one specialist from them also. So they will be throwing more knowledge. So that is why it's the time for collaboration for each and everybody for the holistic health of care. And the science is advancing a lot. That is why so many associations have been made, because each and every association works. Because when the fertility preservation was started by Dr. Abha Majumdar in Gangaram, I started thinking, why he is taking this specialty? Does it have any role to play? And now what we see, it is playing a lot of role to play. So that's why all these associations, when we form them, when we start these associations, I started 5, 6 of them in the Faridabad itself, then at other places also, because I believed that the torch of knowledge has to be taken forward, and in a big way. And Asha, I congratulate you again. I'm really very impressed by your knowledge and by your conduct. And congratulations to all our panelists also. They have done well. Shraddha and our Dr. Ruchika, Dr. Alka, and where is our doctor from Faridabad?
Dr. Kiran.
Kiran, I think, because she has joined from UK. And so Kiran Chandna and everybody, I think they have done wonderful inputs are there by everybody. And our speaker has left, who's talked on
Have you seen any patient on immunomodulating agent like rituximab? They are taking rituximab and all. Anyone has experience of that?
I have seen patients azathioprine and the MABs, and when they want fertility, you have to ask them to go back to the immunologist. They will decrease the doses, and then these patients do well, especially if they have rheumatoid arthritis. Those women, they are in such bad shape, but they withdraw a few drugs. I also had a patient who had some psoriasis.
Yeah.
And she was on azathioprine, but they reduced the dose, and on that she delivered. Only thing is, after delivery, she had some PPH. So we had to manage that, but otherwise there was no major problem.
Yes,
You have
immunomodulators
to
now
keep them
are
on a
being
lot
given.
of folic acid all through. That is my
Some
experience.
patients are coming with myasthenia gravis also, and on immunomodulators, and they are also.
It's a multidisciplinary care of the patients now.
Yes.
We cannot take all that on our shoulders. With multidisciplinary care, I think we can take these for infertility treatment also, and later on for the
Maninder, ma'am,
pregnancy.
I agree. I totally agree that it has to be multidisciplinary, but I also feel that we as gynecologists should know the basics.
Yes.
Bilkul, 100% I agree. That's a very good webinar. It's a very good webinar because we have to know. That is then is the only way we can give the holistic healthcare. Otherwise, we just cannot stick on to our specialty. We have to know what is happening to other specialties. So,
Dr. Maninder, can I add a word for you?
Yeah.
ओवरी रिजुविनेट होए कि नहीं पता, बट आपकी प्रेजेंस से हम सब रिजुविनेट हो जाते हैं.
Thank you
so much.
And actually, the love of all you people and the positivity that keeps me going. I'm a very, very positive person. I never think negative about any person. But let them say anything. It doesn't matter to me. If it doesn't matter to me, that means that vibe has not come to me. That vibe is negative vibe is still with that person. Why should I feel it?
पोस्ट मेनोपॉजल हार्मोन थेरेपी आपसे ही पूछनी चाहिए मैम एक्चुअली.
I don't think madam is into hormonal therapy. I think, the love of life that she has and her living in the present is what is keeping her young. That is my personal take on it. I hope I'm right, ma'am.
Thank you. Yes, you are
Whenever
right.
you meet
Absolutely
her,
right.
see her taste of clothes and her all appearance, it always oozes positivity.